Right. Welcome, everyone, to the Elder Law Training Series presented by Pro Seniors and the Ohio Department of Aging in collaboration with the Ohio Training Advisory Committee of the Alliance of Ohio Legal Aids. We've had 6 excellent sessions in this series so far this year. If you missed any of those sessions, I will put the link to the folder that has the recordings and the materials in the chat in just a moment. In that folder, you'll also find a subfolder for today's session that will have the PowerPoint slides that Erin will cover today. The session will be recorded, and the link to that recording will also be posted in that folder after the webinar today. There will be polling questions during the presentation. If you are an attorney requesting CLE credit for this session, please complete the polling questions. If you have any trouble responding to the pop-up polling question in the window, just put your response in the chat. At the end of the session, a survey will pop up when we close the Zoom. We'd love to get feedback from all participants, but we especially need the survey to be completed by attorneys who are requesting CLE credit. So now turning to today's session, we are happy to have with us Erin Campbell. Erin is an attorney who practiced in litigation with a focus on healthcare false claim acts for 16 years. And then more recently, she joined Pro Seniors as a staff attorney and is here to talk to us today about Medicare. So I will pass it over to Erin.
Good morning. Can everybody hear me okay? All right. So at Pro Seniors, just a little bit about us before we get started about Medicare. I actually started with Pro Seniors as a helpline attorney. And the helpline service is something where anybody in the state of Ohio who's over the age of 60 and has a legal question can call our helpline and talk with one of our wonderful, talented, and very knowledgeable helpline attorneys. They'll provide information, pro se advice, and guidance, and if a referral is needed to an attorney who can help, they can set that up if we've got somebody available, and they're wonderful. We also have a pension help, or like a pension attorney, and this service is open for anybody. So you don't have to be 60. If you have a pension question, if you're looking for a lost pension, call the pension number and see if we can help. Pro Seniors also host Ohio's Senior Medicare Patrol. If if you get your EOB and you notice that you've been charged for something that you did not order or receive or service, it's unknown to you, definitely call the Senior Medicare Patrol to let them know. We also have volunteers who can go to places like public housing complexes or nursing homes or other places to educate older adults about Medicare fraud and scams, if you have any interest in that education. We have a special focus on veteran services and encourage any veteran over the age of 60 to call the helpline. And we host the Long-Term Care Ombudsman Program for Southwest Ohio. If you would like to learn more about nursing home residents' rights, if you know somebody who needs an advocate, if they're receiving poor care, substandard care, or their rights are being violated, definitely call the Long-Term Care Ombudsman. They can also provide guidance about selecting a long-term care facility. Our website has some great resources, and if you just go to proseniors.org and click over on the resources, you'll see that we have legal toolkits. We have Medicare and Medicaid eligibility, which includes a lot of the numbers I'll be talking about today, and then some fact sheets about different medical and other legal topics. And there's a drop down on that. Okay, so the presentation, I think it's going to take us about 90 minutes. If you have a question, please put it in the chat box with your contact information, your email. That way, if you can't stay and get an answer to your question, I can contact you afterwards. We'll go through the basics and history of Medicare, the different types of Medicare, spent a lot of time talking about Medicare Advantage plans. we'll go through the big Part A topics: hospitals, hospice, skilled nursing, and home health. It might be broken up a little bit. I'll talk about the appeal process, and then some of the new issues in Medicare, or observation status in hospitals, some new updates, legislative updates to Part D, prescription drug coverage, and then we've got out-of-network coverage. It's a little bit different if you're on Medicare Advantage versus if you're not on Medicare. The No Surprises Act doesn't apply to Medicare, but it does apply to group health plans, and those protections are important to know about. All right, so Medicare actually it hasn't been around forever, but it was first there's the first thought of having healthcare coverage for older adults when former President Teddy Roosevelt came up with the Bull Moose Party. It was on the platform for that party. Franklin Delano Roosevelt wanted to pass health care coverage as part of the original Social Security Act to go with that pension. But unfortunately, to get the pension provisions passed as part of the New Deal, he had to remove health care. President Truman tried again. His administration introduced health care coverage, but unfortunately, that too did not pass. President Kennedy then tried. He spoke about it, really tried hard to get health care passed, but the American Medical Association was dead set against health care coverage for older adults, and so no luck there. So it wasn't until President Johnson, he had large coattails, and he really wanted to get healthcare coverage passed. So he tasked Senator Clinton Anderson of New Mexico with drumming up support among members of Congress for healthcare coverage. Now, Senator Anderson had a illness all his life. He suffered from tuberculosis. He didn't know he had it until he attempted to enlist in the armed services in World War I in 1917, and the army doctors told him, well, you've got tuberculosis. So instead of going off overseas, he had to go to a sanitarium and spent a couple of years there to recover from tuberculosis. And he fought illness most of his life. So he worked very hard on Medicare, and he actually got sick from his efforts and did a large part of his work on this from a hospital bed at Walter Reed. But eventually, Medicare was passed as part of the Social Security Act of 1965, which set up both Medicare and Medicaid. The bill signing ceremony for this was a pretty big deal. President Johnson held it at the Harry S. Truman Library, and President Truman was enrolled as the first Medicare beneficiary, and he was given a card, and his wife Bess received the second card. So because Medicare is just linked to Social Security, it's actually Title II, Social Security Title II retirement benefits. If you are not eligible for retirement Social Security, you have to pay a premium to enroll. So Medicare originally started as health insurance for those age 65 or older. Later on, those who received Social Security disability became eligible. You have to have received those benefits for 2 years. And then at the same time, it was expanded to those who have end-stage renal disease and are on dialysis. There are 4 large Medicare programs. The first is Part A, which provides hospital, skilled nursing facility, home health, and hospice coverage. The second is Part B, which I would say is everything else covered by Medicare except for drugs. So physicians, outpatient hospital services and treatments, medical supplies. Medicare Advantage is where people who are eligible for Part A and Part B can choose to enroll in a private insurance plan that will provide those benefits. So the government provides a set amount of money to a private insurance plan, and then the insurance plan covers your Part A and your Part B benefits. And that has pros and cons that we'll talk about. The Part C plan can also include prescription drug coverage, or you can retain original Medicare Part A and Part B and purchase a separate Part D prescription drug benefit plan. To be eligible for Part A, you have to be, for an age-based Part A, you have to be 65 or older and have worked at least 10 years in Medicare-covered employment and paid FICA taxes. If you haven't worked 10 years in that setting, you can buy in and pay a reduced premium if you've worked 7.5 years. So if you haven't worked 7.5 years, your Medicare Part A premium will be $505 a month for 2024. If you've worked 7.5 years and you're eligible for the reduced premium, that'll be $278. And then if you've worked 10 years and paid your FICA taxes that long, then it's premium free. You are eligible based on your disability if you're receiving disability benefits and you've done so for 24 months. But that doesn't mean so disability, you have to be disabled for at least 5 months before you can begin receiving the benefits. So typically it's about 30 months from the onset of your disability to when you become eligible for Medicare benefits. That time period's waived if you have ALS. And then if you have end-stage renal disease and you and your spouse have worked 10 years in Medicare covered employment, then you'll be eligible for Medicare as well, even if you're not 65. All right, the process for enrolling in Medicare is a little bit different depending on whether you already receive Social Security or railroad benefits. If you already receive those benefits, so maybe you've elected to receive Social Security early, then you will automatically be enrolled in Part A and Part B, and you'll receive a Welcome to Medicare booklet that'll have information on how to purchase a Medicare Part D plan if you want one. It'll have information on purchasing a supplement plan, which is a good choice if you have decided to retain original Part A and Part B benefits. You might want to purchase a supplement so that'll cover your copays and deductibles, and then you'd pay simply a monthly fee for that insurance. And it'll have your Medicare card. If you're not already receiving a Social Security benefit, it is very important to just set a reminder on your phone, maybe 6 months before you turn 65, that it is time to start researching your healthcare coverage. Because if you don't enroll in Part B in particular, when you turn 65, that can have disastrous consequences if an exception doesn't apply to you. So the 7th month window for initial Social Security enrollment starts 3 months before you turn 65, covers the month you turn 65, and then ends 3 months after you turn 65. And that's the time that you can first choose a supplement plan and have no underwriting. So the supplement plans have to take everybody during this 7-month window. You can't be turned away. And that's not true before or after the window. So if you're on disability benefits, you can be turned away from a supplement plan. At least in the state of Ohio, some states have enacted laws to stop that, so that even those who are disabled can enroll in a supplement plan, but not in Ohio. The other thing is that unless an exception applies to you, you want to enroll in Part B during the 7th month window and Part A as well, because of the penalties for late enrollment. And I'll talk about those in a minute. But first, if you apply before the month of your 65th birthday, you'll be covered as soon as you turn 65. If you wait until the month that you turn 65 or the following 3 months, there could potentially be a gap where you won't have coverage. So definitely, enroll before you turn 65. You want to also make sure that you get supplement insurance at that time as well. If you're planning to purchase that policy. So it's really important to start researching your options well in advance. And as I alluded to, Failure to enroll during initial enrollment in Part B is disastrous financially because Part B has a 10% penalty if you don't enroll during the initial enrollment period unless an exception applies. So everybody who's getting Part B has to at least pay the premium, the $174.70 monthly Part B premium. And if you delay, uh, if you're like, if you enroll 4 months after you turn 65, you're going to have to pay that 10% penalty for the rest of your life. And if you delay like 13, I guess, 13 months, then you'll have to pay like double the penalty for the rest of your life. So you don't want to miss that initial enrollment period. If you're late for Part A, the penalty is not quite so draconian. You pay the penalty, the 10% penalty for Part A, twice the number of years that you did not sign up. So if you didn't sign up until then I don't know, if you sign up like 6 months late, you'll pay the 10% penalty, but you'll only pay it for 2 years as opposed to your entire lifespan. The exceptions to this are if you're incarcerated, then, if you enroll after your incarceration concludes, then you won't have the penalty. Same as if you lost if you're on Medicaid and you lost it, or if there was a natural disaster. A big exception is if you continue to work, and many older adults do continue to work. So if you or your spouse are working for an employer that has 20 or more employees and you are covered by a group health plan, then you can enroll in Part A and delay enrolling in Part B without a penalty, provided that you later enroll in Part B within 8 months of one of these happening, and whichever happens first. So the termination of you or your spouse's employment or the termination of the group health coverage. And something that can trip people up is that COBRA does not count as active employment health insurance coverage. So if you're fired or your spouse is fired, whoever has that group health insurance, and then you're like, I'm going to enroll in COBRA, that does not count to delay the premium. It is very important that you enroll in Part B within 8 months, even if you have elected COBRA coverage. So, during this 6 month before you turn 65 time period where you start investigating your healthcare options, make sure you check with your employer to determine that the group health plan situation that your office or your spouse's office has qualifies you for late enrollment in Part B. And if your employer is changing their healthcare benefits, revisit this issue with them, because there's a lot of moving pieces. There's a lot of requirements. You really want to you don't want to enroll in Part B before you need to because of how expensive it is, but you really don't want to be penalized and have to pay that penalty. So there's a couple things here that can trip people up. A lot of people are turning 65 but not retiring. Delaying receipt of Social Security benefits to age 70 increases your eventual monthly benefit, and the increase is significant. It's 8% per full year that you delay, taking that benefit. So a lot of people delay until they hit 70. And the full retirement age itself is increasing. It's no longer 65. It's 66 and rising. It'll eventually be 67. So folks are continuing to work and may not necessarily be thinking about enrolling in Medicare. So as I talked about, start thinking about Medicare early. If you think you might qualify it, think about financial assistance for those premiums. You can enroll in Medicare premium assistance if your income and resources qualify for it. That'll pay those premiums, the Part B, and sometimes also the Part A premiums. Consider extra help for Part D and also Medicaid. If you have that employer-sponsored healthcare coverage, definitely check to make sure you qualify for delaying Part B without paying the penalty. Talk to a representative at your local Social Security office about the rules that apply to you and carefully write down everything they tell you and confirm that your notes are correct. Enroll in Part B early in the enrollment period so that you don't have a coverage gap. And if your circumstances are unusual, because I'm simply talking general rules, make sure you ask questions about that and don't just assume. Oh, right. So Medicare supplement insurance. It's not the same thing as Medicare Advantage. Um, Medicare supplements are for persons who have decided to stay on original Part A and Part B, but want extra insurance so they don't have to pay large bills. For the Part A deductible, Part B deductible. They want to have just a consistent premium, so they're not facing these large bills. Um, the policies are standardized, and it's set price per the standard policy. You can only buy this policy if you have both Part A and Part B. And it's actually illegal to sell somebody a supplement policy if they have Medicare Advantage. You can't have both. All right, this chart, it's kind of hard to read it, but these are the 10 types of supplement policies. I've included the link. So if you get the materials, the presentation, if there's a link for it, I'm not sure, but I know it's going out afterwards. You can click on the link and see like a larger version of this, and then also a little bit of an explanation about what some of the stuff on this chart is. But as you can see, most of the policies cover some or all of the Part A deductible. A couple of them cover like the smaller Part B deductible. So it's really important to sort of think about what your health situation is, what the cost for these things are, and what you can afford. If you're going to be traveling or not, whether or not you want to have an out-of-pocket limit when you're choosing a part or a supplement plan. All right, so that takes us to Medicare Part A. Medicare Part A's hospital and skilled nursing facilities benefits have what's called a benefit period. Sometimes it's called a spell of illness, but really it's the benefit period. And so the benefit period begins on the first day of your hospital stay. And then it ends after you have no longer been in a hospital or follow-up skilled nursing facility coverage for 60 consecutive days. So it covers your hospitalization, your follow-up skilled nursing, and then the next 60 days. And after that, the benefit period is renewed and a new benefit period will start. All right, so this is from our website. You go to the resources and then the Medicare Medicaid tab that we looked at earlier, and take a look here. You'll see the deductible for Medicare Part A is $1,632. So if you're on original Medicare and you need to go to the hospital, the first thing that'll happen is you'll pay the first $1,632. After you pay that, you pay nothing more if you're a hospital inpatient for the first 60 days because there is no daily coinsurance for the first 60 days of hospitalization. If you're still at the hospital at day 61, there will be a copay of $408 a day. After day 90, that's it for hospital coverage unless you need to use some of your lifetime reserve days. Everybody has 60 lifetime reserve days that they can use. It has a much higher copay there. It's $816. After you're discharged from the hospital, you may not really be ready to go home yet. Maybe you need a follow-up care at skilled nursing. So you need skilled nursing or skilled rehabilitation therapies. Those are physical therapy, occupational therapy, and speech language pathology. So if you're going to a skilled nursing home, under original Medicare, the first 20 days, there's no copay. And then days 21 through 100, there's a $204 a day copay. So keep these numbers in mind because we'll come back to the cost when we talk about Medicare Advantage and do a little comparison with the cost on some common Advantage plans. All right, yep, and there's on the website where you can find this information, the proseniors.org website, under the resources tab. All right, here are some general categories of what Part B covers. Part B, as we talked about, has a monthly premium, $174.70. Part B also has a 20% copay. So for every time you go see a physician or you get your vaccines, if they're not covered, or I'm sorry, if they are covered, or your screenings, ambulance transportation, durable medical equipment, home health under Part B, you'll pay 20%, and then Medicare will pay 80%. Unless, of course, you have purchased a supplement plan that covers that for you. There are some things that are not covered by Medicare that you might think would be. But first, of course, Medicare only covers medical services if they are medically reasonable or necessary. If you don't need the service, it's not covered. They don't cover experimental procedures or treatments, and they don't cover long-term care. So unless you are in that skilled nursing facility stay following a stay at a hospital, or you're receiving hospice care, there is no coverage of long-term care. That comes through Medicaid only, not through Medicare. There is no coverage of dental, eyeglasses, or hearing aids unless they are offered as perhaps a supplemental benefit to a Medicare Advantage plan, or you're getting it through your medical supplement plan. There's a couple exceptions. I mean, if maybe there's a tumor behind your jaw and dental reconstruction is necessary as part of that surgery, well, then of course that'll be covered by Part B. But by and large, these things are not part of the original Part B benefit. Concierge care, if you're paying a doctor a monthly charge to be on their service, that's not covered. And if your doctor has opted out of Medicare, it's really important to know that because there is no coverage for opt-out doctors or opt-out other providers unless it's an emergency situation. And then, of course, you're responsible for paying your deductibles, co-insurance, and co-pays unless that's taken care of because you've purchased a supplement plan or your Advantage plan doesn't charge you for that. If you're not sure if something is covered by Medicare, Medicare has a handy website that you can go to. It's called medicare.gov/coverage. If you happen to know the code for that service, the HCPCS code, you can kind of drill down to in this a little bit more precisely by going to the professional website and entering the code. All right, so that leads us to our first polling question. So Savannah, if you can put up the poll, the question is this. All right, first polling question. I hope you're seeing it. I am not seeing it on my.
Can you see it? Okay, we have some answers already.
Okay.
I think everybody's answered it.
Okay. All right. Well, wonderful. So I'm not going to read the polling question. Hopefully you read it. But I'll just tell you, I put up this photo on the slide. This is from the JFK Library. This is just the transcript or his notes that he's marked up a little bit of a speech he gave trying to drum up some support for Medicare back in 1962. So, okay, should I reveal the answer? Hopefully you all got it.
We have a bunch of people that said they can't see the polling question. So let's read it and then you can put your answer in the chat. Is that okay if we give everyone a minute? I do see it looks like 47 people saw it, but I'm not sure because we see a lot of.
I'm going to read it. I mean,
if I can, there was a poll that was available when the webinar opened. Is that maybe the poll? Because there's no new poll now.
That was it. Sorry.
All right. So I'm going to read the question and maybe, you might, if you want to change your answer or if you need to answer or you're just not sure, just, put it in the comment. It is what it is here. We're doing our best. So the question is this: Which medical service is not covered by original Medicare, even if it's medically necessary? So this is medically necessary for you. Which one of these things is not covered by original Medicare? Number 1, hospital stays. Number 2, dialysis. Number 3, hearing aids. Or number 4, home health. So which one is not covered by original Medicare? 1, hospital stays. 2, dialysis. 3, hearing aids. Or 4, home health. Okay, does anybody need more time to put their answer in the chat box or otherwise answer the question?
I think if you're still putting it in the chat box, go ahead and then we'll note it and you'll definitely get credit for this one way or another. We'll make sure you get credit, but if you want to go ahead with the answer, Erin, I think
okay, the answer is 3, hearing aids. That is not an original Medicare benefit. All right. So let's move on to Part B. I've talked a little bit about this. We have, of course, Part B has the $174.70 monthly premium. Beneficiaries pay a 20% copay on services. There's also a small deductible for Part B. It is $240 a month. I will note that Part B is income weighted. So your premiums do go up if your income is higher. But I mean, you have to be making $103,000 a year before you start paying an increase in that Part B premium. I know most of our clients, like, you just don't expect to see that somebody is paying that, but they may. So just kind of keep that in mind. All right, so let's move on to Medicare Part C, Medicare Advantage plans. Advantage plans are offered by private health insurance companies that are for-profit. They are supposed to offer the same coverage of original Medicare services. As many of us may have seen in our practices, that's sometimes not quite true. There are barriers set up in the system that unfortunately keep people from accessing services sometimes, but they're often cheaper. Maybe not though. We'll look at that. You don't have to enroll in Medicare Advantage. It's completely voluntary. In fact, you have to elect to enroll. People are usually, if you want to enroll in Medicare and you don't pick an Advantage plan, you will just simply have Part A and Part B coverage. And as part of your Advantage plan, you can choose also to have prescription drug coverage. A lot of the plans have a prescription drug component. And if you don't want prescription drug coverage, that's something you have to look out for. Your plan might be a little bit cheaper if you don't elect that coverage, but you won't be able to buy it separately. If you buy a Part C Advantage plan that doesn't have prescription drug coverage, you most likely won't be able to buy a separate Part D plan. All right, so let's talk about some of the drawbacks to Medicare Advantage. Some of the ways that they're able to provide services a little bit cheaper is by having a network of providers. If you pick an HMO, you will be required to see the Advantage plan's network of providers in order for the services to be covered absent an emergency or out-of-area dialysis. If you don't see that network's providers, you have no coverage and you might be facing an enormous bill. If you instead elect a PPO, you'll pay a cheaper bill if you see an in-network provider. But if you go out of network, it'll still be covered, but you'll just pay a little bit more. Advantage plans typically require prior approval before you go see a specialist or hospitalization or pretty much get anything like a medical device. Almost all of that requires prior approval from your Advantage plan. There's numerous types of Advantage plans. Here's the 3 that we commonly see, with the most common being HMOs and PPOs. HMOs and PPOs, often you can find a plan that doesn't charge you an additional monthly premium. So even if you're on Medicare Advantage, you still have to pay that monthly Part B premium, the $174.70 a month. If you're buying into Part A, you would of course still pay the Part A premium as well. But often you can find an HMO or a PPO that doesn't charge an additional premium. There are many that do. Maybe you pay an extra $30 a month for these plans, but there are premium-free plans. But pay attention because HMOs usually are cheaper. Sometimes the PPOs are cheaper. You have to kind of look at what they're offering. But very seriously consider whether you really want to be in an HMO. My big concern with HMOs are if you accidentally go to an out-of-network doctor, there is no cap on that. If you're on a PPO, there is required to be a cap on out-of-network services, combined in-network and out-of-network services, and by law that cap is something like $13,000. So, but if you're in an HMO, out-of-network is simply not covered at all, and there is no cap. We've talked about the other details of both of those. Private fee-for-service plans, for those, there's no network of providers, but you need to take your card with you when you go to see a physician or any other service. And then on the spot, I guess they just decide if they're going to accept your coverage or not. The cost of Medicare Advantage plan premiums is typically cheaper than a supplement plan. I will say, based on experience, what I've seen, supplement plans usually have better insurance. They tend to pay their providers more, and that typically results in beneficiaries getting, unfortunately, like better services sometimes than folks who maybe are on an Advantage plan. Is it supposed to be that way? But the Advantage plans are supposed to cover everything that Part A and Part B does, but I hate to say it, but sometimes you get what you pay for. So if you can afford a supplement plan, that's usually a better choice based on the array of services you're going to get, the coverage options you're going to get. But not everybody can afford to, and an Advantage plan may work out well for many. What you have to pay attention to on an Advantage plan is who is in your network. Are your physicians in that network? Is the hospital you like to go to in your plan's network? And you need to look at this again every single year during open enrollment to make sure your physicians, your specialists, your hospitals continue to be covered. If your Advantage plan offers prescription drug benefits, it is very important that you make sure that your drugs are on your plan's formulary and that they are covered, and that you check this every year at open enrollment. All right, so to prepare for this presentation, I went to 3 well-known insurance companies and looked at their cheapest plan, a premium-free plan, and wanted to do a little compare contrast for you. So hypothetical Advantage plan number 1 is an HMO. For hospital stays, a beneficiary would pay a copay of $310 a day for days 1 through 7. They would pay $0 a day every day after that. And there is a $4,600 cap on all in-network, out-of-pocket beneficiary cost. So you might be thinking, all right, well, Erin, I mean, isn't this better for me than staying on Original Medicare? Because you just told us that if you're on Original Medicare and you go to a hospital, there's a $1,632 deductible that we'd have to pay before anything else. But then, of course, after that on Original Medicare, it's free for the next 60 days. There's no copay. Well, that's true. But let's say you have a 10-day hospital stay. 7 days times this $310 copay is $2,170. So if you're going to be in the hospital, for 10 days in this hypothetical hospital stay, you're already paying more than you would if you had stayed on original Medicare and simply had to pay that $1,632 deductible. And let's say you get out of this hypothetical hospital stay and it's time to go to your skilled nursing facility for some therapy. Maybe you need some physical therapy, occupational therapy after that. What's going to differ between this hypothetical Advantage plan and original Medicare? Well, I looked up all three of these Advantage plans offer the same skilled nursing benefit. For all three of them, you would pay $0 for days 1 through 20, just like on original Medicare, at 0 days 1 to 20 if you're on original Medicare for stay in skilled nursing. All three plans charge $203 a day for days 21 through 100, which is only $1 less per day than what the copay is on original Medicare of $204 a day for days 21 through 100. So the cost for you is going to be very similar at skilled nursing whether you're on Advantage plan or any of these hypothetical Advantage plans or original Medicare. All right, hypothetical Advantage plan number 2 is also an HMO. The copay on this plan is $440 a day for days 1 to 4. So that's $1,760 in total. Of course, that is also more than the deductible for original Medicare. I will say this plan has a higher in-network out-of-pocket cost cap. But when I couldn't get all these details on the slide, but when I was kind of comparing copays for Part B services, this plan did have less expensive copays for Part B. So that's why it's part of why it's important to carefully study the plans. So somebody who might have a lot of ongoing medical expenses but doesn't really expect that they're going to have hospital stays, maybe they're just not sick, they just need to see a lot of specialists, they might be better with Advantage plan number 2 here versus Advantage plan number 1. It just really depends. Hypothetical Advantage plan number 3 is actually a PPO. This health insurance company actually charges monthly premiums for HMOs, but has several premium-free PPOs. So you're, of course, still paying your $174.70 Medicare Part B copay, but it's a PPO. So out-of-network services are going to be covered. You'll have to pay the co-insurance on those, but there's no additional monthly premium. So this plan requires a copay of $375 a day for days 1 through 5 of in-network hospital care, and that totals up to $1,875, which is more than the deductible for original Medicare Part A. All right, so when selecting an Advantage plan, please pay attention to all of those costs. I think, Advantage plans are privately run and they are very good at advertising their benefits, but maybe not so much some of the drawbacks. So it's really important to pull that plan summary for each one of the plans you're considering and compare them. Take a look at the out-of-pocket caps. Make sure that that's something that is affordable to you. If you have to reach it, keep in mind that all the Advantage plans will have in-network caps. For an HMO, there will be no out-of-network caps because HMOs don't cover out-of-network services. PPOs will have also a combined in-network and out-of-network cap. So pay attention to that. And of course, PPOs also cover out-of-network services. You have to pay a copay. So what do Medicare beneficiaries actually do? About half of folks elect to take an Advantage plan. The other half right now are staying on original Medicare and have some other form of coverage. Either they have a retiree benefit that'll cover their out-of-pocket Medicare costs, or they purchase a supplement plan. Okay, so Medicare does have requirements for these plans. The in-network limit on Advantage plans cannot be higher than $8,850. And as we saw on our hypothetical plans, in practice, all three of these plans had smaller caps than that: 4,600, 4,700, and 6,500. The catastrophic cap for PPOs can't be more than 13,300. And of course, they can set lower limits. All right. So as we talked about, definitely Advantage plans have to cover emergency hospitalizations, even if you go to an out-of-network provider. Unfortunately, sometimes they don't, and you might have to fight with your Advantage plan over this, and that's when the appeal process becomes important. If you're in a PPO, you'll probably pay more for the hospital stay, certainly pay more for the hospital stay if you go out of network. And if it's a non-emergency hospitalization, you will almost certainly need prior authorization from your Advantage plan. To be eligible for an Advantage plan, you have to live in the service area for that plan. You have to be entitled to Part A, enrolled in Part B, and now, as of 2021, those with end-stage renal disease can also elect to enroll in an Advantage plan. So when during the year can you enroll in one of these plans? Well, of course, during your initial enrollment period, you can join. That's the 7 months around the time that you turn 65. If you join during the initial enrollment period, your coverage will start the same time your Part B original Medicare coverage would have started, as we talked about earlier in the presentation. Anyone who's eligible can join during the annual open enrollment period, which is October 15th through December 7th. If you join during annual enrollment, your coverage will start January 1st of the next year. There's also a Medicare Advantage open enrollment period every year at the beginning of the year. And if you joined then, your enrollment in your new plan will start the first of the month after the plan gets your request. And then there's also special enrollment periods. And when your new coverage start depends on the circumstance, typically the first month after the plan gets your request. The special election periods for Medicare Advantage happen, like, let's say, your Advantage plan in Ohio, and then you move to Indiana. Well, Indiana might not be in the service area of your old plan, so that move would trigger a special election period where you can elect to enroll in a different Medicare Advantage plan. If you enroll or disenroll in an employer-sponsored Medicare Advantage plan, that'll trigger an open enrollment period. If you disenroll from other employment-sponsored coverage, including COBRA, you can elect a Medicare Advantage plan. If you decided to start with a supplement plan and you terminate it during the trial period, you can do open enrollment in Medicare Advantage, or of course, if there's a natural disaster. Institutionalized individuals are always in an open enrollment period until 2 months after they are no longer institutionalized. And for purpose of this rule, institutionalized means those who are in a skilled nursing facility, a nursing facility, intermediate care facility, psychiatric hospital, rehabilitation hospital, long-term care hospital, or a hospital swing bed. What's not on that list is assisted living. And I do want to talk about that just a minute. Institutionalized individuals are uniquely vulnerable. And we are seeing at ProSeniors that sometimes facilities are affiliated with an Advantage plan. And so look out for your clients. Make sure that they are not being unduly pressured to join an Advantage plan that is affiliated with their facility. Our ombudsman have seen where a plan was include it in initial enrollment paperwork for a facility, and that should not be happening. You know, facilities can only do limited advertising for Advantage plans. I mean, it's like they could put the paperwork, you know, in a brochure advertising area in the lobby. There can be like an information session. If they're asked, they can provide a response, but facilities should not be pressuring residents to join any particular Advantage plan. That's a huge concern because these folks are so vulnerable. Okay, so let's go to prior authorizations. Prior authorizations have been abused. So in 2023, CMS enacted new prior authorization regulations for Advantage plans. The reason they did this was because they observed that these are a barrier to patients accessing medically necessary care. They saw that prior authorization determinations were being made by clinicians who didn't really practice even or know much about the field of medicine in which the prior authorization were sought. They saw like tremendous press challenge. That's something that we have seen here at Pro Seniors as well, where maybe somebody had gotten a prior authorization and then it is demanded they get another one and another one and another one, and they have to keep jumping through these hurdles even though they had already been approved for prior authorization for the same service in the past. This especially has been a problem with electric wheelchairs. And the Office of the Inspector General had studied prior authorizations as well and found that there are so many denials for services that met coverage guidelines. So CMS in 2023 created a new rule, and that is that prior authorizations for coordinated care plans like HMOs and PPOs can only be used to confirm diagnosis and ensure that a service is medically necessary based on CMS standards. Prior authorizations have to be valid for as long as the service is medically necessary. So we shouldn't be seeing these repeat requests for prior authorizations anymore. And Advantage plans have to follow original Medicare's coverage criteria where it has been established. So that means if there is a statute, if there is a regulation, if there is a local coverage determination or there is a national coverage determination explaining how a service is medically necessary, then the Advantage plan has to follow those rules. If there is not publicly available criteria in one of those fashions, then the Advantage plan has to set criteria and make it publicly accessible. The criteria can only be unspecified and not publicly accessible in very limited circumstances where they can demonstrate that the additional criteria provide clinical benefits that are highly likely to outweigh clinical harm, including harm from delayed access to services. And the Advantage plans have to set up now utilization management committees to review their prior authorization policies and ensure that they are consistent with coverage requirements, including those specified by original Medicare. So if you or your client or your family member has questions about Medicare, supplemental policies, prescription drug plans, Advantage plans, you do, a good starting place is to call the Ohio Senior Health Insurance Information Program and get some answers to those questions. All right, so that takes us to poll slide number 2. And can everybody, oh, good. Okay, I see the polling question. So the polling question is this: true or false? Medicare Advantage plans must cover the same services as original Medicare and that coverage must, it's not maybe worded as well as I should have done so, but that coverage must follow the same statutes, regulations, and coverage determinations as applied to original Medicare. Is that true or false? So Advantage plans have to cover the same services as original Medicare, and their coverage rules must follow the same statutes, regulations, and coverage determinations as applied to original Medicare. While you're answering that poll question, I have another photo. This is from the Social Security's website, and this is that bill signing ceremony I talked about earlier that happened at President Truman's library. And you can see some recognizable faces from history here. President Lyndon Johnson is signing the Medicare bill, and sitting next to him with the glasses, the brown glasses, tortoiseshell glasses, that's President Truman. Wearing the blue dress is First Lady Lady Bird Johnson. Wearing the yellow dress is former First Lady Bess Truman. And if you could and the Vice President Humphrey is sort of standing right next to Bess Truman. And if you kind of see, there'll be a better picture of him later, like back in the back left corner. I'm pretty sure that's Senator Clinton Anderson, who I talked about, but we'll see a better photo of him later. Okay, has everybody gotten a chance to answer the polling question?
Okay, I'm going to go ahead and end it.
All right, the correct answer is true. Yes. Advantage plans have to cover the same services as original Medicare, and their coverage requirements, I'm sorry that's so poorly worded, have to follow the same statutes, regulations, and coverage determinations as applied to original Medicare. All right. Let's see if we can move on. Okay. All right, I'm going to skip over that. We talked about that earlier. Those are the co-payments and deductibles for hospital coverage. And we'll move on to hospice. So hospice is an original Medicare benefit. You have to be entitled to Part A to get it. And you have to be certified as terminally ill with 6 months or less to live if the illness runs its normal course. When you elect hospice coverage, you are waiving your right to Medicare payment of services that are related to your terminal illness, other than services provided by the hospice and your attending physician, if the attending physician you have is not employed by the hospice. So anything meant to treat or cure your terminal illness is not going to be covered by Medicare anymore unless it's a treatment designed for symptom control or pain relief. Hospice does not usually cover facility, room, and board except in 2 circumstances. There's respite care available for your caregivers, and sometimes inpatient care is medically necessary if you really need that for pain control and symptom management. Medicare will still cover benefits that are unrelated to your terminal illness. So if you're in hospice and you break your arm and you need to go to the hospital to get that set, that'll still be covered by Medicare. And if you're on an Advantage plan, your Advantage plan will still cover services that are not related to your terminal illness. And original Medicare will cover everything that is related to your terminal illness. Cost for this, usually almost everything is covered by a hospice. There's a 5% copay for 2 things, and that would be your hospice drugs. And if you're doing an inpatient stay, there's a 5% copay for that. Okay, the rules for skilled nursing facilities are important and a little complex. I'll try to break it down here, but we're going to come back to this later on when we talk about observation stays in hospitals. So a stay in a skilled nursing facility is, generally speaking, covered by Medicare and considered medically necessary under these circumstances. First, you were admitted to skilled nursing within 30 days of your discharge from inpatient hospitalization. That inpatient hospitalization has to have lasted at least 3 consecutive days, not including the date of discharge. You also have to require either daily skilled nursing services or skilled rehabilitation services at least 5 days a week. And the skilled rehabilitation services are physical therapy, occupational therapy, and speech language pathology. You also have to need care in skilled nursing that is related to the condition for which you were hospitalized, um, or that occurred in skilled nursing while you were being treated there for your hospital stay. And skilled nursing is no longer necessary when one of two things happens. Either you're needing skilled nursing services and you no longer need them, or you're receiving skilled rehabilitation therapy services and you're either no longer improving with that therapy or you're no longer needing the therapy to stop from getting worse. So for the therapy, the skilled rehabilitation therapy to be medically necessary, you either have to be continuing to improve with it or you would be getting worse without it. As a practical matter, it's very hard to convince skilled nursing facilities to cover you when you would be getting worse without the therapy. That is a lot harder of a case to make. So you usually see it phrased as, all right, you're no longer getting better, so this skilled nursing coverage is no longer appropriate. One other thing I want to point out, Advantage plans can elect to cover a stay in skilled nursing if you haven't had a full 3 days of inpatient hospitalization. But it is required. The 3-day hospitalization is definitely required for original Medicare. Okay, so if you're in a skilled nursing facility, that coverage is going to include your room and board, the therapy services, social services, your drugs, your biologicals. If you need ambulance transportation, that'll also be covered. As we talked about, there is no copay on original Medicare for days 1 to 20. After day 21, there's a $204 daily copay. And if you are choosing an Advantage plan, you really need to pay attention to, is there a deductible for this? Is there a copay? How is that structured? Okay, home health care. Home health is covered by both Part A and Part B, but for home health to be medically necessary, one of these two criteria has to be present. First, the patient either cannot leave their home because of an illness or injury, or needs the aid of supportive devices, specialized transportation, or the assistance of another person to leave, or it's medically contraindicated for them to leave their house. One of those two things meets the first criteria. The second criteria is the patient has a normal inability to leave the house or it would require considerable or taxing effort. So I've got a couple examples of when these criteria might be met. The first is a patient has lost the use of their upper extremities and therefore is unable to open doors, use handrails on stairways, and requires assistance of another individual to leave their place of residence. That's one example. Another one is a patient has just returned from a hospital stay involving surgery and is suffering from weakness and pain because of the surgery. And for that reason, their physician has restricted their actions, or their physician only wants them to do a very limited amount of certain activities, such as, well, just get out of bed, only a few times a day and only when needed for specific things, or don't walk up and down the stairs. In those cases, these are just two examples of reasons why home health might be medically necessary. Home health covers the cost of part-time skilled nursing and therapy services, a part-time home health aide, social services, and medical supplies that you might need in the home. So this might be like help with walking, bathing, grooming, changing bed linens, help with feeding, help with injecting osteoporosis drugs for women, covers DME, medical supplies that you might need at home, intravenous or nutrition therapy, monitoring an unstable health status. Part A covers 100 home health visits. You know, if you've had that three consecutive day hospital stay, and the home health visit is rendered within 14 days of your hospital discharge or skilled nursing facility discharge. After that benefit is used up, you're still eligible for coverage of home health under Part B, which offers unlimited coverage as long as it's medically necessary. Home health is nearly entirely covered for free by both Part A and Part B, with one exception. Part B home health has a 20% copay for medical equipment and osteoporosis drug. So, what happens when your Medicare or Medicare Advantage plan makes a decision that you don't agree with? What can you do? Well, you can appeal. All beneficiaries have a right to a notice if a service is denied, in most cases. And that notice will tell you how and when to file an appeal. If a service is denied and you don't get a notice, or you get the notice and you're not sure how or where to appeal, contact OSHIP. You can appoint a representative to help you with the appeal. In certain circumstances, you can request an expedited appeal. And this is really important if you are being terminated from home health, skilled nursing facility coverage where you need a quick turnaround. Because if you're terminated from skilled nursing, you should be getting a notice that tells you how much the daily rate's going to be. And you will want to appeal very quickly because you don't want to stay in skilled nursing if you can't afford the room and board charge if Part A is no longer going to cover it. But you really still think you need the care. Appeal quickly, do the expedited appeal, and you should get an answer very quickly after the agency that you're appealing to has all the information you need. You know, stand by the phone so that when they call to ask you questions, you're immediately available to answer those questions. Okay, so the appeal process is lengthy, and don't give up if you don't get an answer that you don't like initially, because you will not talk to a truly independent person on appeal until you reach the third stage and you're in front of an administrative law judge. The first appeal, if you're on original Medicare, you have 120 days within getting the initial determination to appeal. If you're on an Advantage plan, you have as little as 30 days. It's 30 days if you haven't gotten the service yet, or if it's 60 days if you're simply requesting payment and you've already gotten the service. The second level of appeal goes to a contractor who is not typically associated plan if you're on Medicare Advantage. You have 180 days to request the second level of appeal if you're on original Medicare, and then the same 30 or 60 days if you're on an Advantage plan. The third level of appeal is pretty similar for those on either original Medicare or an Advantage plan. The amount in controversy has to be at least $180, and you need to make the request within 60 days of receiving the adverse decision. The fourth level of appeal is the last administrative appeal. You have to appeal within 60 days, and that appeal is heard by the Medicare Appeals Council. The fifth level of appeal is filing a case in federal district court. There has to be at least $1,840 in controversy. Okay, this is a chart that might be a little bit hard to read. It gives you a little bit more specific information about the appeals process for the different parts of Medicare. I just recommend clicking on the link to see that. in a larger format. It is time for poll slide number 3. Poll slide number 3, true or false? There are 5 levels of appeal of denial of Medicare claims for those who are both on original Medicare and those who are enrolled in a Medicare Advantage plan. True or false? And while you are answering that question, I have on the screen a photo of President Truman's original application in the Part B program. So you can see he has elected to get supplemental medical insurance. He signed his enrollment application, and his witness was President Johnson. All right, has everybody gotten a chance to answer the polling question?
I'll give it like 10 more seconds and then I'll shut it
Okay.
down.
Okay. You'll notice they put his social security number on his application. And so, all right, great. Most of you got the answer correct. It is true. Okay, so observation status. We talked a little bit earlier about how you can qualify for coverage of skilled nursing. And one of the key points was you have to be in an inpatient stay in a hospital for at least 3 days, not including the date of discharge. But just because you go to the hospital and you're staying there, and you might even be staying overnight, doesn't mean you are on an inpatient stay. You might be getting tests, getting x-rays, receiving observation services, hanging out at that hospital in a hospital gown, but you might actually be on an outpatient stay and not even know it. Or you could be in an inpatient stay and retroactively determined to be on an outpatient stay. That can happen too. This makes a big difference because if you proceed on to skilled nursing and you were on an outpatient stay, you're not going to get that skilled nursing stay coverage, and that could be a disaster for your finances. Inpatient stays are also usually cheaper for patients because of the low cost of the first part of the Part A stay. Outpatient services can be very expensive. If you're on an Advantage plan, there's going to be a daily rate for that. The same is true for original Medicare. And if it's outpatient, I mean, you're paying for every service. Every test is going to have a copay. You're also responsible for your drugs. If it's a self-administered drug, it's not covered by Part B. You want to bring your drugs from home. So you don't have to pay for those drugs out of pocket if you're on an outpatient stay. So in recent years, there is a problem where CMS was observing high numbers of medically unnecessary hospital stays because hospitals are trying to get patients through their 3 days so that they will qualify for post-hospital rehabilitation services at skilled nursing. So now there is a 2 midnight rule, and Part A inpatient admissions are only appropriate for those who are expected to stay for 2 midnights. Advantage plans, though, can use their own coverage criteria. So as a result, hospitals are placing patients on observation status, even if doctors want them to go to skilled nursing afterwards. But Medicare now requires that hospitals give patients something called a Medicare Outpatient Observation Notice, or a MOON, if they are receiving outpatient services for at least 24 hours. And time is going fast, so I'm not going to spend a lot of time on this, but if you get this MOON, definitely read through it, call the Medicare hotline that's on it, and realize that if you have the MOON, you're an outpatient and skilled nursing may not be covered. All right, so because these observation stays have been so devastating to beneficiaries, there was a federal lawsuit over the issue of the fact that CMS had no requirements that there be an appeal process if you are put on observation status. So even under the results of the lawsuit, if you just go to the hospital and you're on observation status from the get-go, you have no appeal rights. But certain people now do have appeal rights. If you were formally admitted on an inpatient basis and then subsequently were reclassified as an outpatient, you can appeal that determination as soon as, well, actually, you will be able to appeal that determination as soon as these regulations that are in draft form are finalized by CMS, which hopefully happens soon. You will also be able to appeal if you were not enrolled in Part B at the time you went to the hospital, and you got stuck on outpatient status. And if you stayed at the hospital for 3 or more consecutive days, but were designated as an inpatient for less than those 3 days, you will hopefully soon have appeal rights. So there's a lot of outrage over this outpatient issue. There's outrage over the 3-day stay. I mean, as you know, everybody wants to get out of the hospital as soon as it is safe for them to get out of the hospital. No one really wants to stay the 3 days if they don't have to. And CMS certainly doesn't want to be paying for medically unnecessary stays. So there have been in recent years like numerous legislative proposals to fix all of these problems. I think it would be great to do away with the automatic requirement that you have to be in the hospital 3 days to qualify for post-hospital care. There's other requirements. This proposed legislation right now would count time spent on observation status towards the 3-day requirement. And that gets us to poll question number 4. Poll question number 4 is, which part of Medicare covers observation stays? And your choices are Part A or Part B. And in the photo, we have Senator Anderson shaking the hand of former First Lady Bess Truman at that same bill signing ceremony. All right, so I'll give you all a few seconds more to answer this question. Which part of Medicare does Part A cover observation stays, or is it Part B?
We'll do about 10 more seconds and then I'll shut it down.
All right, I'm hoping I get all my own questions right.
Okay.
All right, yes. Part A covers inpatient stays. If you are not so fortunate to be ordered into an inpatient stay, your stay will be covered by Part B, and all the supplies and tests and things will be Part B services, which you will be paying 80% copay or whatever your copay is under your Medicare Advantage plan. Okay. And we're gonna try to go pretty quickly because I know we're nearing the end of our presentation time. Part D can be covered as a standalone or as part of an Advantage plan. When picking Part D coverage, again, really pay attention to the premium, the deductible, what is available during the coverage gap. I mean, how much are you going to be paying on your drugs when you're in the coverage gap or the donut hole? And very important, are your drugs on your plan's formulary? Every Part D plan has a formulary. They have to offer 2 drugs in the most common categories. Plans can change the formularies. If the change is due to, unless that change is due to new information on drug efficacy or safety, then if you're currently taking the drug, you are exempt from the formulary change for the rest of the contract year, and that drug has to continue to be covered. If it's not, then you have to be given 60-day notice and a 60-day supply of the drug. If your drug is not on the plan formulary, there will be no coverage. You can request an exception, though, from your Part D plan, but you will probably be paying more for that drug because the Part D plans try to lower prices by negotiating with drug manufacturers for lower prices for drugs on their formularies. Okay, so when you join a Part D plan, you are going to pay a set amount as a copay on your drug based on, like, essentially is your drug a generic? Is it a preferred brand drug? Is it a less preferred brand drug? And depending on what tier your drug is in, generic, more preferred, or less preferred drug, you'll pay a different amount of money. But once you hit the donut hole or the coverage gap, you will be paying 25% of the cost of your medication. And in 2024, the coverage gap starts after there have been $5,030 worth of services, or drug services, and there are certain things that count towards that, like the deductible, the co-insurance, co-payment. Once you're in that coverage gap, sort of counting to your running total is the discount on brand name drugs. Premiums and pharmacy dispensing fees do not count towards the amount of money that goes to, like, when you hit the coverage gap and then when you're out of it. And if you are on extra help, you do not have a coverage gap. You are never going to face this problem. So if you are within 150% of the federal poverty limit, call Social Security, apply for extra help so that you are not facing a coverage gap and you get a little bit of help on your premiums. Okay, the Inflation Reduction Act of 2022 made some vast improvements to Part D. One of the most immediate ones was that insulin is now available at $35 per month per covered prescription with no deductible. There's access to adult vaccines without cost sharing, certain vaccines. There is an expansion of the Extra Help program to reach those up to the 150% of the federal poverty limit starting this year in 2024. And starting in 2024, once you are in the coverage gap and come out of it, and your out-of-pocket spending, it's $8,000, then you will pay nothing further on drugs because you are in the catastrophic phase. Next year, it will get even better. The catastrophic phase will be reduced to $2,000. So once your out-of-pocket costs are at $2,000, then you're done. Oh, another change next year. So typically when you go to the pharmacy, you pay for your drugs. If you're getting a 3-month supply, that might be a lot of money. Starting next year, all Part D plans and Advantage plans with drug coverage have to give you the option to pay instead a monthly capped amount. That should help folks balance out their finances a little bit better. A very, very exciting change that drug manufacturers are going to hate is that starting in 2026, there are being negotiated drug prices on the 10 most expensive drugs as negotiated by CMS. I'm so happy about this change. It really needs to happen because some of these brand name drugs, there might only be one drug and it is so expensive. So, the drug manufacturers are currently suing the government over this, and I really hope this goes through because it will be a huge change for folks who need to take these very expensive drugs. Okay, so this leads us to out-of-network services. If you're on original Medicare, everybody is in network for you as long as they haven't opted out of Medicare. Because most physicians, hospitals, providers take original Medicare, it's typically not going to be a problem. There's just no network to be worried about. If it is an emergency situation and on your Advantage plan, all the Advantage plans are supposed to pay out-of-network providers for emergency and urgent services and out-of-area dialysis. Easier said than done. That might be something that has to be appealed, unfortunately. If you're in a PPO, there's an annual cap on the combined in-network and out-of-network cost. As we talked about, that cap can't be more than $13,000 and change. And if you're going out of network, beneficiaries will typically pay 100% of the cost if you were on original Medicare fee-for-service, minus the co-insurance that's covered by the plan. And then, of course, Advantage plans, no out-of-network cost because they don't cover an HMO, no out-of-network costs because HMOs don't cover out-of-network services. Now, not to be confused with the No Surprises Act, because the No Surprises Act does not apply to Medicare Advantage plans or any other government healthcare programs. It applies to group health plans. So if your client maybe bought a plan on the marketplace, or you got a plan on the marketplace, the No Surprises Act will apply to you. And what this means, if you go to an emergency room and that emergency room is not an in-network hospital for you, the No Surprises Act will protect you from unexpected out-of-network charges for the emergency services that you receive from the hospital, from any doctor or other provider giving you care at the hospital, and from air ambulance providers. You will still pay your normal cost sharing, including co-payments, co-insurances, and deductibles. If you are seen by an out-of-network provider at an in-network hospital, you're protected from those out-of-network charges, but there is no similar protection if you go to a doctor's office. If you go to an out-of-network doctor, you are not covered by the No Surprises Act. And then there are certain types of insurance plans that the No Surprises Act does not apply to, including vision and dental only insurance, and the others listed here. Okay, so let's say you were in the hospital it's an out-of-network hospital. You are receiving emergency services. You are then stabilized, and the hospital wants to start being able to collect those out-of-network increased fees from you. You may be presented with a notice and consent form. You can't be presented this form if you are in the middle of your emergency, or if perhaps you are like really not competent to sign this form. But if you're presented with this notice and consent form and you do not want to pay out-of-network charges, you should refuse to sign it. So never, ever sign a notice and consent form that protects you from additional out-of-network charges, because this form can only be offered to you to sign if there is an in-network provider available. So if you refuse to sign the form, the notice and consent form, then the hospital has two choices. They can send the in-network provider to come and treat you, or they can just swallow the cost. It's their choice. So don't sign the notice and consent form to avoid who knows how much in out-of-network charges. If you have questions, call those No Surprises help desk. They can answer them. Great, so we have made it to about 11:30. And I would really be happy to take questions if you have them. If you can't stick around to answer a question, just put your contact information and I'll send you a follow-up email afterwards. And while we're looking at those questions, I just went to the National Archives and found out that the signing of the Medicare and Medicaid Act is one of the milestone documents of the United States. So who knew? And here's a lovely photo of it. Okay.
All right. Erin, we have one question so far from
Sure.
Marie. How do facility fees figure into this?
Okay. So Marie, are you still there? And what kind of facility are you talking about?
Yes, I'm still here. And oh, wait, can you hear me?
I can, yeah.
Okay, so and I'm talking about the kind where you go to some place that you think is a doctor's office and it turns out to be a facility and you get charged a facility fee for walking in the door.
So you go to a doctor's office and it turns out to be like an outpatient facility.
Right.
And so
are you familiar with this, or am I just making things up?
I'm sort of thinking that I have been to some place like this.
Yes, you probably have.
Okay, and then what kind of insurance do you have when you go to this facility?
So so say I'm a Medicare recipient.
Okay, so most likely the facility is going to be an outpatient facility. And so you show up and you're thinking you're going to be just paying for this doctor, I guess, and then you get charged a outpatient facility fee that you didn't know about. And it's Medicare. So No Surprises Act doesn't apply to Medicare. I would say your best bet when you walk in the door is to ask what the charges are, but if you haven't done that, then yeah, you could appeal. Medicare appeals are kind of tough, but they're not very hard to bring. at least at the initial stage. So write a letter explaining what happened, get a copy of your records. And if the records show that all you were doing was seeing that doctor, you might have an argument that whatever this facility fee was completely medically unnecessary and not covered by Medicare. I think I would start with that for a Medicare beneficiary without knowing a little bit more about the situation.
Thanks. That's a great advice. Appreciate it.
Okay, anybody else have a question?
I do not see any more in chat at the moment, just some thank yous. So last call for questions. Okay.
All right, well, thanks everybody for coming.
Thank you. Thanks so much.
See everybody today, and take care.
Thanks, Erin. Thanks so much for presenting today. And we look forward to hopefully seeing most of you back on October 11th when we'll hear about veterans benefits. So thanks, everyone. Thanks a lot, Erin.
Have a good weekend.